Hello, and thank you for joining us. Welcome to MLI's Community Collective, Harnessing the Power of the Community to Battle Obesity. This is the first of a three-part series talking about the importance of starting a conversation with your patient about an obesity diagnosis that MLI is honored to bring to you in partnership with the Florida Obesity Society. Part two will be another virtual activity using the same link you used today, next Thursday, September 19th, also at 6:30 p.m. Eastern, that will look at some of the new and emerging data on anti-obesity medicines. In the third week, we will all meet together for a live in-person event at Bird Tampa at the Armature Works on Thursday, September 26th. Our hope is that after participating in both virtual sessions, you'll join us live with any remaining questions or challenging cases. This exclusive event is for you to network with your colleagues so that you feel comfortable making a difference in the lives of your patients who face the challenges and comorbidities that come with overweight obesity. It's not too late to register if you have colleagues who weren't able to join us tonight, as long as they register, and we'll put that link in the chat. This session will be available to them on demand at their convenience through the Zoom events portal to view prior to joining us next week or at the live. So tell your friends and make it a date. Now, before we start, let's warm up with a couple of pre-test questions. Please answer on the pop-up. Among the following comorbidities, which has the greatest rate of co-occurrence with obesity? Okay. Next question, pre-test question 2. Your 44-year-old patient with a BMI of 36 kilograms per meter squared presents to the clinic for an annual visit. She has a history of dyslipidemia and hypertension. What percent body weight loss is needed to see a therapeutic benefit in her hypertension? Question 3. Which of the following are true regarding semaglutide and tirzepatide? Thank you for answering those questions. So with all that said, it's my great pleasure to introduce one of the leading experts in the field of obesity medicine, Dr. Lisa Ferreira, an obesity medicine physician practicing at the Advent Health Bariatric and Metabolic Institute in Tampa, Florida. She is board certified in family medicine, and lifestyle medicine. Prior to joining Advent Health, Dr. Ferreira practiced family medicine at Baycare Medical Group for 15 years before she began to incorporate obesity medicine into her practice. She received her medical degree from Sidney Kimmel Medical School and her residency and chief residency at Bayfront Medical Center in St. Petersburg, Florida. Dr. Ferrer is an active member and fellow of the Obesity Medicine Association and serves on the board of directors for the Florida chapter of the American Society for Bariatric and Metabolic Surgery. Dr. Ferreira is also a founding member and current president of the Florida Obesity Society. Dr. Ferreira, thank you for joining us, and I'd like to turn this activity over to you.
All right, excellent. Well, thank you so much. I really appreciate all of you being here. And I'm going to share my screen with the slides that I have for us tonight. Okay. Wait for that to pop up. There we go. All right. Well, thank you so much, everyone, for being here with us tonight. So, I really appreciate your time. I know that this is a busy time. So, thank you for being here. We are going to talk about the disease of obesity. And so, I'm so excited to be able to bring this to you. So, like was mentioned, I have a background in family medicine. So, I was in family medicine for 18 years. And about 12 years into my career, I realized that, I really wanted to offer more for my patients, just try to figure out how to help with this obesity that I was seeing worsening and worsening. And so, fortunately, I realized there is a board certification in obesity medicine. So, about 6 years, 6, 7 years ago, almost 8 years ago, I guess now, I got into obesity medicine and loved it so much that I wanted to do it full time. So, now here I am in Tampa at the bariatric surgery department and working here doing the medical weight management. And I love what I do. So, I hope that I can help you love this part of your practice with your patients. It's challenging. So we're going to go through some information. And then we'll do our second session next week. And then we'll have our live session together where you can feel free to pick my brain, ask questions, and we'll discuss further. So I'm going to start through the slides. So we started this slide because this is just important for us to remember that obesity really, it is a disease in itself. And it actually does affect every organ system in the body. I mean, there are over 200 complications or comorbidities or chronic conditions that we think are related or associated with obesity. So you can see here just a sampling of those, but it really is all over. And so we really have to think about obesity a little differently, I think. I was trained that obesity was something the patient did to themselves. This was their willpower and they just need to fix it. And we were going to treat all of these other medical conditions and not worry so much about the weight. And now we realize that obesity being a chronic disease, we need to think about focusing on that. But we also know that when obesity affects so many other medical problems, we can treat these other comorbidities in our patients by also addressing obesity. So you can see that changing paradigm from treating separate medical problems to actually addressing the underlying cause, which oftentimes could be related to obesity. All right, so we're going to move slides. Okay. So when we look at the prevalence of other diseases or other comorbidities or complications with obesity, you can see the numbers here that 75% of our patients with hypertension also have overweight or obesity. You can see down at the bottom, over 90% of our patients with type 2 diabetes have overweight or obesity. So I think that was one of our questions. So you can see it's really just, it is related. These comorbidities that we are treating every day in our patients, if we start with the treatment of obesity or incorporate that, we will likely make a big difference in these other conditions. How about the percentage of patients who have diabetes who also have obesity? So when you look at the numbers, you can see the blue bars are the percent of the US population or the prevalence of diabetes in the US population. And you can see that the latest stats show about 2017, 2018, we're at about 14% of our US population, our US adults. But what about the percent of patients with diabetes with obesity? So with a BMI over 30, and you can see those numbers dramatically increase. So the latest numbers, 78.8 or almost 80% of people with diabetes have a BMI over 30. So again, back to why do we want to treat obesity? Because we can really make a difference in these other comorbidities. So looking at that post-test question, now I think we know the answer to this one. So among the following comorbidities, which has the greatest rate of co-occurrence with obesity? And that's going to be D, type 2 diabetes. So when we think about treating obesity, and people think, well, maybe it's going to take a lot of weight loss to really make a difference. A patient may need to lose 20, 30, 40, 50 pounds before we see a difference. And really, that's not the case. We can see changes in our complications like preventing diabetes. You can see on the left side, hypertension, dyslipidemia. When you look at the amount of weight that's required to start really making a dent in these conditions, you can see in the middle, hypertension, for example, at a 5% body weight loss, you can already start to see an improvement in their hypertension. Dyslipidemia, 3 to about a 15% body weight change can really make a difference. So at 3% body weight change, we can already start to impact these comorbidities. Now, some of them are a little more difficult. So you can see here that MASLD, the new term for NAFLD, is at about a 10% body weight loss, or sleep apnea is a difficult one to get at a lower body weight loss. But still, you can see the benefits of incorporating weight loss. And it doesn't have to be dramatic. It can be almost anything is going to start to make a difference in some of these conditions. So when we look at that post-test question again, this other post-test question, we can see now our answer. So 44-year-old patient with that BMI of 36, the history of the dyslipidemia and hypertension, what percentage of body weight is needed? So you can see that the answer here would be at least 5% with the max benefit at greater than 15%. Now, when we look at our diagnosis of diabetes, so we're going to talk about, or I'm sorry, our diagnosis of obesity. How do we start to diagnose obesity? And we have traditionally used the body mass index, or the BMI. BMI is tricky because BMI was actually started as a measure from the insurance industry to kind of get the risk of a population of insured patients at a certain weight for medical problems and cost to the insurance company, really. So on a population level, it can do a pretty good job at assessing risks. But when we think about the individual in our office, that BMI is not necessarily reflective of what is actually happening. So we don't really like it on the individual level. Now, unfortunately, it is an easy measure. It is something that our EHRs calculate quite easily. It is something that the medical community or insurance companies do use as diagnostic criteria. So for now, until we can change this, we are still limited to looking at the BMI at least. So when we do look at a BMI, you can see on the right side these weight categories based on their BMI. So a healthy weight would be an 18.5 to 24.9. Overweight is 25 to 29.9. The class 1 obesity would be 30 to 34.9, and then class 2, 34.9 to 39.9, and obesity class 3 at greater than 40. So what I also like to point out on this slide is that we are using our diagnoses of obesity in categories or classes, so class 1, 2, and 3. What I see oftentimes is still reported morbid obesity or some of these other terms that really can be discriminating, can be insensitive, can be difficult for our patients. So we're really trying to focus on the naming it as our classes of obesity. But BMI does not take into consideration multiple factors as well. So when we look at things like bone density or muscle mass, or we look at body fat percentages, doesn't take into account race or genetics very well. We use one number across the board for everyone, and that's just doesn't seem to take into account all of these other variables. Diet and exercise. I point out here sometimes with my patients when we talk about BMI that someone like The Rock, Dwayne Johnson, for example, if he walked into my office, his BMI would probably be quite high, but I don't think we could diagnose him with obesity. So it really is not reflective of the person. So a better way to assess a person's individual risk with obesity and overweight is to think about doing a waist circumference. Now, waist circumference is something that's a little sensitive, and so we'll talk about how to do that so that it is more comfortable for you as the provider and for the patient. But when we look at the benefits of looking at waist circumference, the hazard ratios for the waist circumference, you can see in these graphs, so men and women, for all patients, healthy never smokers, you can see those travel together, and the hazard ratio increases as the waist circumference increases at the bottom of the screen. So we know the impact of waist circumference on our overall health. So again, back to those classifications. So overweight and obesity, you can see those here. What we also want to look at is our risks of diseases and progression of diseases. So we can look at a risk based on the class of overweight and obesity, but we can also look at it as how it relates to waist circumference. So when you see here that you see the BMI criteria, And then the middle column is men and women with waist circumferences that are considered to be in the more normal range. And then the last column are waist circumferences for men and women that appear to be in the obesity range. And so when we follow a patient example on the right side, for example, we can see that a person in your office might have a weight of 234, a height of 70. So their calculated BMI would be 34, but their waist circumference is actually 45 inches when you measure. So what kind of risk would that put this person? You would think based on their class of obesity that that might be just a high risk. But now you see that if you use a waist circumference measure for their risk, they're actually at a very high risk of disease as opposed to what you would expect with the high. So again, just illustrating the point that BMI doesn't always reflect the risk to the patient, whereas the waist circumference is a much better measure. So how do we do it? Because it can be pretty sensitive, right? So to think about reaching around a patient, it's just an awkward position to be in. So we want to make sure that we are doing our waist circumference correctly. So we want to locate the top of the right iliac crest, or just the iliac crest, the top. So I usually ask patients to kind of put their hands on their natural hips, and then you can kind of find it that way as well. But the top of the iliac crest. Then you put the measuring tape at a horizontal around the at the iliac crest, and ensure that the tape measure is snug and it should be parallel to the floor. And then you record it at the end of normal expiration. So we're going to show a video actually to illustrate that principle more clearly for you. I'm going to buzz through it because I don't think we need all of the
For patients with a
words here,
BMI
but
greater than 25 but less than 35, measuring waist circumference can provide additional information about the patient's risk of complications from obesity. The first step is to ensure.
okay, I'm going to help this along. So the first step is to obviously make sure you're in a secure location. Of course, we're doing this probably in our exam rooms. We're going to ask permission just to say, is it okay if we take a quick measurement of your waist circumference? Then we're going to have the patient take the tape measure and hold it themselves at the top of their iliac crest. So we'll locate that. We'll put the tape measure there. They'll hold it at that spot. Then you'll grab the other end of the tape measure and you'll ask the patient to spin around. And as they do that, then as they come all the way around, then the tape measure, you'll go back to the original spot, then you'll take it from them, and then you will have your parallel to the floor waist circumference.
Ensure that the tape measure is parallel to the ground. The tape measure should be snug but should not compress the skin. Ask the patient to take a deep breath and exhale. Take the measurement at the end of the exhalation.
So you'll notice that with this, it's not necessarily at the umbilicus. We think sometimes that it's just that should measure up together with the iliac crest, and it doesn't always. So the umbilicus is not going to be a good measurement for you. It's also pretty dependent on the person doing it. So if you're going to have this done in your office, I would suggest training your staff, someone reliable that you use often, your medical assistant maybe, and really help them be comfortable with doing this correctly, because the technique matters and the consistency with the measurement matters.
For patients with a BMI.
All right. So now we're going to talk about a case study. So we have an example of someone who you probably see multiple times a day in your office. This is a 42-year-old woman who came into your office for her annual wellness visit. And so on exam, here are her vitals. So you can notice that her weight, 197, height, 62 inches. So waist circumference was measured at 41.5 inches, but her BMI is 36. So you decide to do blood work for her and decide to follow up again to review the labs. So you can see here that her recent lab work showed that her glucose was at 110, so a little elevated, so prediabetes, A1C at 5.9, we have prediabetes, and looking at her lipid levels, don't look too unreasonable. Her exam from the last visit, you can again see those vital signs. And so now we want to do a visit to follow up on those results. So this is kind of funny to me. When I was preparing this, I was thinking, I'm not sure we really do this as a telemedicine visit. I don't know about texting my patients during the visit, but the point of this is to say that we are going to follow up with our patient as we do all the time on their lab work, ask if we can, cover anything else for them. Just want to go through the blood work. The provider tells her about her elevated blood sugar, and she's concerned about it, does not want to develop diabetes. So we talk about what can we do, and then they're going to set up another appointment to talk about treatment strategies later in the office. So I don't do telemedicine visits that way, but I'm sure you don't either. But the idea is to devote some time to discussing this further.
Honestly, I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
So she has a concern about the diabetes. Now, our concern, of course, the developing diabetes, of course, but also our concern is addressing weight, I think. So when we start to have that conversation with the patient, we just want to make sure that we're sensitive about terms that can be discriminating or can be sensitive to the patient. So you can see here words that we want to avoid, and I'm sure we are well aware of this. We hopefully are not doing this in our office. I'm sure we're not. Obviously, we're not going to refer to someone with these offensive words: fat, chubby, extremely obese. Just even getting that word obese out of our language would be beneficial. And we'll talk about that more here in a minute. But thinking about more unhealthy weight, overweight, weight issue, weight problem, unhealthy BMI, or unhealthy weight. So we can use terms that are better for our patients. We also want to use that person first language. So, and I know I was trained way back forever ago when we talked about that diabetic or that morbidly obese patient, the obese patient. And we really want to get away from putting the disease ahead of the patient. We really want it to more be the patient with a condition. So the patient isn't defined by their disease, the patient has a condition. So instead of obese patient, thinking about patient with obesity. I know this takes practice, and I find myself slipping up sometimes as well, or the patient with diabetes, the patient with cancer, not the diabetic. It takes some practice, but we want to be thinking about that. So also thinking about some bias that we may have. Again, I was trained forever ago when we thought that weight was someone's problem and it was willpower and they were doing this to themselves. And if they just took better care of themselves and ate better and moved more, that they would be fine. But apparently they're lazy and they just don't want to do it. We know now that really is not, it's not that simple. It's not that the case is that at all. So we want to think about our own biases and how we were trained and try to remember that obesity is a disease. If we had a patient in our office with cancer, we typically would not shame and blame them and expect them to cure their own cancer, just go do better. We would treat that as a disease. So we are thinking about obesity in the same way. So recognizing, you can see at the bottom, one of the points here, recognize that obesity has many factors and a lot of them are outside of someone's control. There's the role of genetics, hormones, female hormones, stress hormones, the environment, our food environment. There's so many pieces that play into this. So just remembering that this is a complicated disease. And I always start by just explaining to my patients, number one, you have a disease of obesity that we are going to work together to try to put in remission, but this will be something we will be working on for the long term, and that this is not your fault. This is not that you are just lazy and you need to do better. This is a disease that is complicated and multifactorial. So thinking about patients have experienced weight bias from other providers. Sometimes I have patients come in and they're very sensitive. They don't want to talk about weight, or they're already ready for me to tell them that they need to go do better, and that they're thinking, what is she going to tell me? She's going to tell me the same thing I've heard over and over. So to really create that safe space when we're talking to our patients and say, yeah, I understand that. I'm sure you can see here, tried repeatedly to lose weight. Most of our patients have tried at least 7, 8, 9, 10 times to lose weight, and they find that the weight always returns, and we'll talk about that. So just being sensitive to that, and remembering that this is a chronic disease. Asking permission to talk to patients about their weight. Would you mind if we spoke about that? Some patients aren't ready. And if they're not ready, then okay, if you feel like you are ready to address that with me at some point, I would love to talk with you about that further. And let me know if and when you want to talk about that further. Open the door to no judgment, no blame. If this is not your time to address that right now, Okay, but here's a safe space to do it when you're ready. Talking to them about the effects of obesity. So if you don't lose weight, you will have this problem, or this problem you have is because of you're obese. As opposed to that, thinking about bringing it back to obesity can be related to certain cancers. Obesity can be related to diabetes. So like our patient, if we're thinking about helping her prevent diabetes, maybe bringing in how about, is it okay if we discuss your weight and how that relates to helping you reduce your risk of developing diabetes? So let's see what our follow-up looks like.
Honestly, I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
That does sound overwhelming. I hear you. You want to make changes for your health and your future, and I'm here to lend support. Do you mind if we talk about your weight and where you feel you are right now?
Am I going to get diabetes if I don't lose some weight? I'm not happy with my weight, but I just honestly I don't even know where to start. Ever since I lost weight a few years ago, it's just been so hard to not only lose more weight, but just even maintain the weight loss.
So that's what we hear a lot of times too, is I don't know where to start. Patients just don't know what to do. Now, these days, there's a lot of social media attention on weight. Thankfully, I think that patients are asking more for help, and they know there are other tools out there that we will talk about. But they also know that their efforts to lose weight sometimes can work, and then the weight comes back. It seems to just reoccur. So looking at this graph, this would be an example of this patient's weight journey. You can see that there are times where she began a supervised diet program and exercise. But then life happens. She got laid off, started a new job, a breakup. So weights can fluctuate because of stressors and just other things happening in life. And so you can see the weight went down, it goes up. And this is a typical journey for someone struggling with their weight.
The
The
slow upward drift in calorie intake on a new diet is not because you got lazy. Once your appetite is boosted by 600 calories after dieting for a while, eating 200 calories less at the end is as hard as eating 800 calories less at the beginning. So you can maintain the same disciplined level of willpower and self-control and still end up stagnating.
So the point here is thinking about this concept called metabolic adaptation, and we're going to break that down and discuss what that exactly means. But first, when you think about what's happening when patients are trying to lose weight and they're restricting calories, the first thing they think of is, I just have to eat less. And that may work temporarily, and their weight will start to come down. The problem is that when they restrict calories, the body is evolutionarily set up to not want to die of starvation. So hunger signals go up, fullness signals go down. The body wants to then eat. So now the patient is experiencing more hunger than they were originally to try to keep that weight down and try to keep those calories down. It becomes even harder and harder. Plus, we look at the other factor. So we used to say that this was just calories in, calories out. It was as simple as just eat less, move more, and that's all you have to do. Strict calories in, exercise more to get the calories out, and you're good to go. It's more complicated than that, as you can imagine. So we also look at the calories in and how the hormones change so that the hunger increases. So that's one thing working against the patient. The other problem is that when we look at our energy expenditure, so total energy expenditure, calories burned, we would think that meant exercise, when in fact, there are a lot of factors in there. You can see here that actually your resting metabolic rate accounts for over 50% of that energy expenditure. So, and that's not something that you have direct control over easily. So over 50% of that is kind of out of your control relatively. There's also the thermic effect of food, and that is just the calories burned in digestion. And you can see that accounts for another percentage, maybe 15, 20% or so. Then that NEAT is the non-exercise activity thermogenesis, and that means just your daily movement that is not intentional, that is fidgeting, or that is movement. Anything you do that's going to burn calories to some degree, but not intentional, is also called NEAT. And then you have the exercise part. So you can see here when we tell patients to go exercise to lose weight, that's the smallest part of their actual daily energy expenditure.
During one season, some of the Biggest Loser contestants famously had their metabolic rates tracked. Above and beyond the hundreds of calories less it takes to just exist 100+ pounds lighter, by the end of the season their metabolic rate slowed by an extra 500 calories a day. The mind blower was that 6 years later they were retested and still had the 500 calorie a day handicap. So the contestants had to cut 500 calories more than anyone else their size to maintain the same weight loss. No wonder the bulk of their weight was regained. Most remained at least 10% lower than their starting weight, though, and even a 7% drop has been shown to cut diabetes rates about in half. Still, the metabolic slowing means you have to work that much harder than everyone else just to stay in place.
Yeah. So metabolic adaptation is also where the metabolism, when you are losing weight, your metabolism actually goes down. And that Biggest Loser study, so there was that show, I'm sure we're all familiar with the Biggest Loser show, where people went to this ranch, they worked with a trainer, they lost a significant amount of weight, and then they followed them out 6 years to see what happened. And it turns out, as they were losing weight, their resting metabolic rate decreased. But then they started to regain weight again because their hunger signals increased, their metabolism was slower, and actually their metabolism never bounced back. So their metabolism stayed down as their hunger signals were going up. So it's not just calories in, calories out. There are so many factors. There are increased hunger signals, there's decreased metabolism. So despite our best efforts, our body is working against us. So weight loss can actually decrease your resting metabolic rate by about 15%. So you can see the graphs here that resting metabolic rate can go way down. Also, a smaller body. So once you've lost weight, your metabolism goes down. So you need, and it requires fewer calories to maintain that weight. So you're hungrier, but you need fewer calories. And if you increase your calories, you're going to most likely gain that weight back. So it's very complicated, for us to say, well, the patient just didn't do what they were supposed to do and they gained their weight back. And why couldn't they be consistent with what they were doing? It's because the body is working against them.
Yeah, sure. So I work on film sets. I put up together all the different props and everything like that. It can be pretty physically demanding. I do work up a sweat as I'm setting it up, but once I'm done with that and the set is set up, I will sit down for most of the day. So as far as food goes, the studio usually provides us with meals, but they aren't really super healthy. Oh, and I also like to take walks with my boyfriend on the weekends. They typically will be about 45 minutes, maybe an hour long, depends on the weather. But honestly, just thinking about finding time to exercise more just seems really overwhelming.
So you've definitely heard this story. When patients come in and talk about weight, there is certainly the component, the lifestyle changes that we need to help our patients be able to develop. So there are pieces that our patients can really jump in and make a difference. So thinking about helping our patients start this journey, they've decided that they do want to do something about their weight. It is time. They're ready. We have things we think about, this shared decision making, and we do this with our patients. I know I'm preaching to the choir here, but what I like to point out are a couple of these pieces. So, ask those leading questions. Don't interrupt the patients. Of course, this is basics that we do with our patients. I even find that I still struggle with that sometimes. I'm in a hurry and they're telling me a long story, and I'm still, today, I was thinking, okay, all right, let's get to this. I know what I need to tell you. So sitting back and taking a breath, I know I have to work on that myself. But discussing with the patient that this is truly a disease, and this is something that we're in together. This is not perfection. This is the long haul. We're going to make some adjustments together. We're going to come up with a plan that they're comfortable with. Discuss specific diet and exercise goals, and we're going to talk about how to do that, because yes, the patient's on board, they're ready to go. You've discussed with them the benefits. Now, what do you actually do? So SMART goals are where we usually start. And, thinking about helping our patients develop goals. Patients say, I know I want to lose weight. I'm going to leave this office today. I'm going to follow up with you 1, 2, whatever months, 3 months, and I'm going to do better. I'm going to do better is tough. So we have to come up with specifics. So whatever nutrition plan or diet or whatever you think, at least helping the patient make some SMART goals, some adjustments that they feel like they can achieve. So when we think about SMART goals, it stands for specific, measurable, achievable, relevant to the patient, and a timetable or a time scale. So the more specifically you can nail them down, okay, you want to, for example, start exercising. Wonderful. What are you going to do? Who is going to go with you? So are you going to start walking with your husband? Are you going to go 2 miles? Are you going to do it with your husband, with the dog in the neighborhood in this lab? Why do you want to, what would you think that would accomplish? Well, I want to build some stamina. I want to build some muscle mass. And when are you going to do this? And for how long? So I'm going to do this for 15 minutes on Monday, Wednesday, Friday at 4:30 p.m. Once I've picked the kids up from school, like as specific as you can get with them. That's going to be more likely for them to be able to achieve this. If they walk out saying, I have to exercise more, then chances are they're going to come back and not have been able to do that as successfully as I have a schedule. I know exactly what I need to do. Same thing with their nutrition. I want to improve my nutrition. Great. Where are we going to start? Okay, well, let's start by I'm going to add more vegetables in my day. I'm going to try to increase my protein by I'm going to start eating breakfast and I'm going to have some eggs. Like making it more specific is really going to help them be more successful. So now the case study goes on that our patient came back after 3 months and has lost about 5 pounds. She has tried some nutrition changes, tried some physical activity changes. And so now the conversation goes on about what other tools can we help for her to be able to be more successful with her weight loss. And is this something you want to discuss further? So you can change your genetics, but adjusting your physiology, adjusting your chemistry, adjusting the chemistry in the brain and those hunger signals and fullness signals could be very effective, and medications can help with that. And also lower cardiovascular risk. So having this conversation with the patient, would you be willing or would you be interested in talking about other tools we have available? Now, this is something that is controversial, I guess. Sometimes we think about our patients who come into the office and want to have some help with their weight. They want a medication or they want some assistance with weight. Some providers would say, well, yeah, but they need to prove to me that they have tried themselves. And so we need to go 3 months of diet and exercise. And then when they come back, depending on how they do, then we'll start a medication. And I can see the idea behind that. I can see the logic behind that. And I think that that is appropriate for someone who has never even thought about weight, has not made any adjustments, has a lot of adjustments to make. And I think that that might be reasonable. But I think also I have this discussion up front with patients. I think that by the time, especially patients have gotten to me, they have done it, been there, tried it, especially patients who've struggled since childhood with their weight. How many diets have they tried that they've seen their weight go down and come back up again? So I never prescribe medications, anti-obesity medications to patients without covering nutrition and physical activity and sleep and stress and these lifestyle changes. But I feel like if we can give them a tool that's going to help them be able to make those adjustments easier, then I think they'll be even more successful. So it's up to you and the feeling that you have and the discussion with your patient as to whether this is what you would do at a 3-month follow-up, or is this something you feel comfortable doing sooner? So when we think about pharmacotherapy and in the anti-obesity medications, there are limited options for us right now. Now, I will go through the options and we'll talk about them. We do have much more effective options these days, and there are plenty of medications coming in the pipeline. So that's the great news, is that we are going to have more tools to offer to our patients here. So this is a great time to be in obesity medicine because we're at the beginning of this explosion, I'm sure, of lots of tools for our patients. So when we think about medications for weight management and anti-obesity medications, or our AOMs, we classify them into 2 different generations. So there's the first generations and then the second generation. This chart gives you a breakdown of the first generation anti-obesity medications. And so you can see the names on the left, the generics and the brand names. These are still great options. I do use them for my patients, for the right patients. You can see that they do result all the way on the right side. They do result in some weight loss. Now, the weight loss, depending on the person, depending on what you're trying to address, can be variable, but typically somewhere around 3, 5, even maybe up to 10% in some studies on the phentermine topiramate or the Qsymia. But I think there's still great options for some patients. The phentermine, though, is tricky because I know when I was trained, phentermine being a controlled substance and approved by the FDA back in the 1950s, it was classified as a controlled substance. It was also classified to be used for 3 months at a time maximum. And this is unfortunate because now that we have newer medications like the Qsymia that incorporate phentermine and are approved for long-term use, we are starting to understand better the safety of phentermine when used in long-term. And again, when we think about the disease of obesity, this is a chronic disease. So to offer someone a prescription for phentermine for 3 months, their weight comes down. This tool is helping them in addition to their lifestyle changes. The weight comes down, and then in 3 months, we say, well, we have to stop the medication because we're not allowed to have you on it for more than 3 months. And then what happens? The weight comes back. And again, we know that that's not necessarily because the patient wasn't doing what they're supposed to do. This is because the tool you were giving them to help them with weight, we now took away. If a patient has hypertension and we have them on antihypertensive medications and their blood pressure is well controlled and we keep them on the medicines for 3 months, and then we take the medication away and say, well, your blood pressure looks good and you can't be on it anymore, what's going to happen? Their blood pressure is going to go back up again. We would never think to do that with hypertension. So again, rethinking obesity. Now, this is tricky because the FDA hasn't quite gotten on board with phentermine and extending the use. So still on label would be that 12-week usage. But if you pull me aside later, we can always talk about my other opinions on that. Orlistat is another one that we actually don't use so much these days. This was an older one that is a fat blocker. And so you can imagine if patients are eating any kind of fats, avocado or nuts, or some of these things that some people would classify as healthier fats, they're going to have quite a few GI side effects that are going to be very unpleasant. So orlistat's kind of fallen out of favor these days. But these other medications, the Qsymia or phentermine topiramate, the naltrexone bupropion, the Contrave, they can be valuable for certain patients. Liraglutide or Saxenda is also somewhat falling out of favor because it is a daily injection, because the production of it is now much more limited, and because the weight loss from it is not nearly as great as we're seeing with our newer agents. We also want to think about our adverse reactions or adverse events or things that can happen with these medications. So just to highlight some of these here, common side effects versus more serious side effects. So what I like to point out on this one is that, thinking about phentermine, and I know the serious could be pulmonary hypertension, valvular disease. These are extremely rare in patients who are just on phentermine. Where this was a bigger problem was back when we had fen-phen, so phentermine and fenfluramine. Fortunately, fenfluramine has been pulled off the market, so we don't see this nearly as much. Obviously, we're going to be aware of just watching for these things. I also, if patients have a cardiologist on board or they have any cardiac history at all, I like to get a cardiac clearance for the phentermine, at least run it by the cardiologist and make sure that they feel that this is a good option for your patient. The other thing to point out here is to be careful with the Qsymia and the Contrave, thinking about history of seizures, especially for Contrave. So if a patient has a seizure disorder or a history of seizures, you want to avoid that medication. The phentermine topiramate, when you look at the side effects versus phentermine, it's the topiramate that has created some of these. So the suicidal ideation or behavior, the glaucoma warning there for you, the cognitive impairment, those are related to the topiramate part of this. And we're familiar using topiramate for other conditions in primary care, so you're familiar with how to manage that. Now, when we think about managing other conditions, so we think about diabetes. diabetes being associated with obesity, and thinking about, can we treat obesity at the same time we're treating diabetes and get dual benefits? So this came from the diabetes care, the standards of care in diabetes in 2023. So the updated algorithm for treating diabetes. And you can see on the left side of the screen, for our patients who have heart disease, heart failure, kidney disease, these newer second generation anti-obesity medications are GLP-1s, GLP-1 GIP agonists, are also beneficial for our patients for other reasons. So they are great for diabetes treatment. Obviously, they're very powerful, but they also have protective effects as well. So when you see this algorithm now, it's changing. This algorithm is helping us be more aware of what else we're treating. We can treat diabetes and just treat sugars, but we can also treat other conditions. When you look at the right side of this algorithm, and I'll blow that up here, you can see that the goal of treating diabetes should also be incorporating treatment of obesity. So our lifestyle changes, everything we do, we're going to start with our lifestyle changes, of course, and then we're going to look at the lipid lowering or the glucose lowering therapies that we can use that will be weight friendly. So whenever I have a patient come in who has diabetes and they're on things like insulin or sulfonylureas, the first thing I try to do is to figure out, how can I decrease those medications or hopefully stop those medications at some point and switch them over to medications that are also beneficial for weight management. So you can see on the right side of the screen, thinking about our anti-diabetes medications that are effective for weight loss. So what can be very effective are our semaglutide and tirzepatide. You can also see here that even highly effective for weight loss could be the other GLP-1s. So you could use those as well. The SGLT2 inhibitors can cause a little bit of weight loss also. And I even use metformin. Metformin, for some of our patients who don't have coverage for these medications, can't afford these medications, or have reasons they can't use them, metformin could be beneficial for weight. It's not dramatic and it's not FDA approved for that, but especially in our patients with prediabetes or diabetes, most patients, it wouldn't hurt to have that in the background as well. So thinking about these second generation anti-obesity medications, what are we talking about? So we're talking about our newer medications, the semaglutide and tirzepatide. So when we think about what the definition of now a second generation anti-obesity medication is, or what that means, it could be defined as either the ability of that medication to produce an average of greater than 10% placebo-subtracted weight loss in clinical trials, or the ability to produce greater than 15% weight loss in over half the patients in a study. So now looking at that chart, when we update that chart, we see that we've added to the bottom the second generation anti-obesity medications. And so semaglutide, or in the form of Wegovy, that is FDA approved for weight loss, and tirzepatide as the name Zepbound. So patients will come in and say, well, I just want that Ozempic stuff. Well, or I just want that Mounjaro stuff. If they don't have type 2 diabetes, chances are insurance is not going to cover that for them. So the weight loss or the anti-obesity medication versions are the Wegovy and Zepbound. But you can see here that they also work by decreasing appetite. Pretty much everything we do these days in the way of pharmacotherapy is working in different ways to decrease appetite. But you can see all the way to the right, the weight loss that we would expect from these newer medications. And now we're approaching 10 to 16% with Wegovy, 15 to 21% with Zepbound. So we're really getting much more effective weight loss with these newer medications. And we're treating diabetes or pre-diabetes if they happen to have that. And we now know that we have some other added benefits, like with semaglutide, with Wegovy, our cardiovascular risk reduction for recurrent heart disease is a new indication that came out about that as well. And there are so many studies happening all the time on these medications, and you'll see in the news all the time benefits that are coming out in sleep apnea, in renal function, in treating MASLD. And so lots of other benefits that we're seeing happen. So it really is an exciting time to see all the research that's happening. So this third question, post-test question 3, which of the following are true regarding semaglutide and tirzepatide? And it would be B, so greater or equal to 15% weight loss in over half the patients with obesity as an adjunct to lifestyle modifications is true for those medications. So the actions of GIP and GLP-1. So GLP-1 we know is secreted. It's a natural hormone that our body makes anyway. It is secreted from the L cells in the small intestine, but it's also secreted from areas in the brain. It works in a variety of ways, and we're still learning about the effects of GIP and GLP-1 and what they're doing. We know there's brain activity. So you can see on the top here, it may improve neuron survival, suppress inflammation, improve neurogenesis. They're studying these medications in Alzheimer's disease and dementia. It will slow gastric emptying. So that's how we get some of that fullness feeling from these medications. So we're not only working in the gut, but we're also working in the brain. Just more information about these actions. So you can see GLP-1, GIP, what they're doing behind the scenes, and working in a variety of different ways. So the GLP-1, you can see cardioprotection, delayed gastric emptying, increased pancreatic function, glucagon goes down. What we do realize, or we think, is that GIP used alone in studies was not shown to be effective for weight loss, actually. There are some conflicting mechanisms that happen with just GIP, but we think GIP added to the GLP-1 can actually boost the effect of GLP-1 or augment that or increase that effect.
GLP-1 and GIP. The GLP-1 is a hormone produced in the small and large intestines. It is released in response to food intake and stimulates insulin secretion and suppresses the glucagon secretions, but only when there is glucose in the bloodstream. The GLP-1 has also other beneficial effects. It slows the absorption of carbohydrates, resulting in low blood glucose levels after meals. It also causes loss of appetite, and animal studies have shown that it can promote the regeneration of pancreatic beta cells and improve the survival of existing beta cells. The GIP hormones are produced by cells in the upper small intestine, and they are released when glucose comes into contact with these cells. Like GLP-1, the GIP acts on pancreatic beta cells, where it stimulates insulin secretion and also appears to promote beta cell proliferation and survival. GIP may complement the action of GLP-1 receptor agonists. In preclinical models, GIP has been shown to decrease food intake and increase energy expenditure. Therefore, the combination with a GLP-1 receptor agonist may have greater effects on markers of metabolic dysfunction, such as body weight, glucose, and lipids.
So that video is interesting. I watched that and laugh at that poor woman who was looking at her food, even a healthy salad, and she's just not happy. That's a little interesting to me because my patients don't seem to approach their food in that way. They are relieved that the food noise has calmed down, that they feel more normal. I have patients say, this is what normal people feel like, not constantly thinking about food or constantly hungry. So I think she should have looked a little happier than she did. But that the idea of that freeing them from the food can be life-changing for patients. So we're going to talk more next time, our next session. We're going to do a deep dive into those medications, our second generation anti-obesity medications. And so we will go through that in quite a lot of detail. But I think that slide went away. There we go. So if you did want to scan the code, then you could do that to claim the credit. But this is just a reminder about our other sessions. And I wanted to leave time for some questions. So I am going to open it up for any questions that you may have.
Hi. Hey, hi.
Hey.
Hey, it's Rajni Shah. I was wondering about, do you feel like there's going to be any role in Rybelsus or the oral semaglutide in help with weight loss? Because as of this point, there isn't, but.
Right. That's a great question. And so again, all the stuff that's coming, and we know that there are trials right now because Rybelsus right now, the doses that are used, the 3, 7, 14, I think,
14.
those are treating diabetes, but they're not so effective for weight. So what they're finding is that it actually takes doses 25 or even 50 milligrams. And I think it's going to come out probably both, but the dose will probably be 50 milligrams for the treatment of obesity. So it's just not right now in the right doses. So I do have patients who come in on Rybelsus for weight loss because maybe their insurance covers that and that's how they're going to get their semaglutide, but it's usually not effective at those doses. But it's coming. So yeah, hopefully here soon.
Yeah.
Yeah, because it would be nice to have an option for patients who are needle phobic, right? Who are afraid of the needle. I can usually talk patients through that, and I have demonstrator pens. It's usually not a big deal, but some of our patients really do want to use the oral, and so it will be coming.
Oh, that's great to know. Thank you.
Yeah, sure. Good question.
Dr. Ferreira, there's a question in the chat. Do you recommend any specific protein intake goals for patients?
Yeah, so I do. And fortunately here, working in bariatric surgery, we think about the same type of nutrition oftentimes, especially with, again, our second generation medications, because their appetites get so suppressed that we do want to make sure we are prioritizing protein and fluids. So my personal goal for most people is somewhere around 80-ish or so grams of protein a day. I think that's a pretty standard for our bariatric patients as well, 60 to 80-ish. I'm actually a fan of pushing the protein, especially with patients who I fortunately have a body composition. So I have a bioimpedance machine and I can really keep up with their muscle mass. So if I start to see the muscle mass going down, I want to push the protein even further. So over 100 grams. It depends on the person. If you have a larger muscular man, you're going to probably want to push that protein a little bit more as well. There are formulas. So some people will say to use a formula of 1 gram of protein per kilogram of body weight. But sometimes, depending on how you calculate that, it's people use the weight they are, and it could put them 180, 200 grams of protein a day, which is definitely difficult to accomplish, especially for people who are on these medications and their appetites are so reduced. So it really should be calculated based on their lean body mass. So somewhere around even, if you said 80 to 100-ish, but I have no problem pushing the protein. I tell most of my patients that realistically, I don't find people can overdose on protein, again, especially on these medications. And then the types of protein too, thinking about how can patients get in enough protein if their appetites are so suppressed. Sometimes they do use meal replacements. They'll use protein shakes. And so helping our patients pick the right protein shakes, there are lots of different ones out there. The best ones have about 30 or more grams of protein in them. So something like a Premier Protein, Fairlife, Ensure Max, you want to look for these types of protein shakes, or the powders that you can mix with things. I usually have patients, if they're going to use a powder, mix it with water or some unsweet almond milk. So we're not getting extra sugar from regular milk or juices that patients might use, and have them be very careful with adding fruit into those. I explain the difference for my patients between smoothies and protein shakes. Smoothies have tons of sugar, lots of fruit, and maybe protein if we're lucky, maybe peanut butter, maybe milk. And before you know it, you have 1,000-calorie smoothie, as opposed to a protein shake is going to be less calories and higher protein amount, and then careful with the fruit.
Thank you so much, Dr. Ferreira, for wonderful discussion. We are actually just going to put the post-test questions back up on the screen. And if you wouldn't mind taking a minute to answer the post-test questions, that would be great. Again, the questions are: among the following comorbidities, which has the greatest rate of co-occurrence with obesity? Okay. Question 2. Your 44-year-old patient with a BMI of 36 kilograms per meter squared presents to the clinic for an annual visit. She has a history of dyslipidemia and hypertension. What % weight loss is needed to see a therapeutic benefit in her hypertension? And finally, which of the following are true regarding semaglutide and tirzepatide? Thank you again, Dr. Ferreira, and thank you everyone for joining. We look forward to continuing the discussion next Thursday, same time, same link. If you are interested in claiming continuing education credits, the link is in the chat, mli.link/obesity Tampa 1. Thank you so much. We'll see you next week.
Thank you so much, everyone. Have a great night.
Thank you.